Dear respected students, I am Nurgul ma'am, and today I want to lecture about syndrome of exocrine pancreatic insufficiency. Before starting discuss this syndrome, I'd like to go back to anatomy of pancreas. As you know, from first and second courses, and pancreas has two parts, exocrine and endocrine parts, and endocrine parts release the hormones which are releasing directly to the blood, and endocrine part consists of islands of Langerhans with the three kinds of cells, as alpha cells which produce the glucagon, beta cells which produce insulin, and delta cells which produce the somatostatin. Alpha and beta cells, they both regulate glucose level of blood, but somatostatin regulates releasing of insulin and as well as glucagon. But today we are not interested in these endocrine parts. We will discuss later in hypo and hyperglycemia syndromes. Today we will focus on deficiency of exocrine part, and you know, exocrine part of cell or exocrine part of this pancreas produce to release enzymes into the duodenum, which helps digest carbohydrates, proteins, and fats in our digestive system. Here is structure of the exocrine part, and exocrine part consists of this acinus and ductus, and cholecystokinin and secretin and other biological active products. They can induce the production of proenzymes which activates, and also secretin can activate the production of bicarbonates. And pancreatic juice consists of enzymes and also bicarbonates. Etiology of exocrine pancreatic insufficiency very large and includes many pathologies, and one of etiological factors is removal of part of organ, or etiological factor may be as obstruction of ducts, whole diseases which can result in obstruction of ducts. It's maybe tumor or any anastomosing pancreatiginal anastomosis, or pathological changes in the vessels of pancreas, as atherosclerosis, inflammatory thrombosis, embolism, or pancreas can damage by chronic alcohol abusing due to alcohol intoxication, or alimentary factor. Alimentary factor is fatty, fried meat food in combination with alcohol can also damage the pancreas. This is risk factors. And one of etiological factor may be pancreatic hypertension. All diseases which can result in pancreatic hypertension, increasing pressure in pancreatic duct because of disturbance of going out pancreatic juice. And also chronic diseases of duodenum, as duodenitis or penetrative ulceration of duodenal ulcers, they can result in damaging of pancreas. Under pathogenesis of pancreatic damaging lies destructive defeat of acini and caused by intracellular activation of the enzymes, and progressive as a result, progressive fibrosis gradually leads to a violation of the physiological function of gland. Pancreatic gland has very large compensatory phase, and even till damaging 90% of pancreas may be non-clinic. After damaging of more than 90%, may develop clinical pancreatic insufficiency. As we mentioned before, Pancreatic insufficiency syndrome always accompanied by two syndromes as malabsorption and maldigestion. You already know what is malabsorption. This disease when developed decreasing absorption of nutrients as carbohydrates, as fats and proteins, and also disorders of digestion of all these kinds of foods as maldigestion. Here are presented composition of pancreatic juice, and pancreatic juice consists of three types of enzymes like proteolytic enzymes, lipolytic enzymes, and amylolytic enzymes. Proteolytic enzymes is not only trypsin and chymotrypsin, also includes carboxypeptidase A, carboxypeptidase B, elastase, glycerine. Lipolytic enzymes as like lipase, colipase, and phospholipase. Even pancreatic juice can destroy the not only lipids, also phospholipids. And you know, all our cell membranes consist of phospholipids. And amylolytic enzymes as amylase. Also, you should know another source of amylase. And other enzymes like aranase and deanase. And this is our pancreatic juice also contain bicarbonates. Bicarbonates is very good buffer and can also regulates the acidity and alkali condition in duodenum. So you should know that amylase can other sources, not only pancreatic amylase. There are two kinds of isoforms, as P isoform and S isoform. And P isoform as pancreatic is about 35-45%. And as isoform can other sources as salivary glands, liver, small intestine, kidneys, and during damaging of these organs and salivary glands and liver may also increase level of S amylase. And S amylase may also includes or may also increase in any kinds of tumors like ovarical tumor or esophageal or lung tumors. That's why that's why increasing amylase is not only belongs to pancreatic damaging, may increase amylase in other kinds of diseases also. Also, we should focus on the lipase. You see daily released lipase daily released about 200,000 till 400,000 units per day. And optimum pH of action of this lipase, this is from 6 to 8. It's also very important if due to any cases, any reasons we have increasing or decreasing pH from this normal range. In case of duodenitis, for example, when alkali condition of duodenum change into the acidic condition, we have a problem with activation of lipase. And lipase doesn't work in that condition. Clinically, endocrine pancreatic insufficiency appear by stool disorders, and we will discuss very closer further. Abdominal discomfort is also stool variation of consistency of the stool. It will be marshy liquid stool with this steatorrhea because of disturbance of destroying of lipids. And clinical manifestations of malabsorption as decreased body weight and decreased absorption of all whole products like carbohydrates, fats, and proteins. Clinically, also can represented by pain syndrome, and particulars of this pain syndrome. This is circumscribing character of pain is most typical for pancreatitis, and typical radiation of pain to the back, less often to the left shoulder, scapula, left half of the thorax. At the beginning of disease, this pain occurs after 30 to 60 minutes after eating and persists for 1 to 3 hours. But in chronic pancreatitis, when progressive disease and become to pancreatic duct become to be scarring, pancreas become to be scarring and fibrotic, pain lose its connection with food and becomes permanent. Here is points pain points in pancreatitis. For example, here represented Desjardins point, located 6 cm above the navel, along the line connecting the navel and the right axillary fossa. And here is point of caput of pancreas. Also, we should assess another point of Meyer-Robson point on the border of the outer and middle third of the line, which connects the navel and the middle left of costal arch. And here is body and tail of pancreas. Clinically, pancreatitis and pancreatic insufficiency syndrome also can be represented by dyspeptic syndrome, decrease or lack of appetite, salivation, nausea, vomiting, not bringing relief, flatulence, and stool disorders such as diarrhea. Diarrhea most predominates in this clinic. And clinically, pancreatic diarrhea, what does it mean? It's a large volume, it means polyfecalious, grayish color with unpleasant odor, with drops of fat because of steatorrhea. And clinically, during observation, you also can see red drops on the skin of the chest, on back, abdomen, appear red spots, round shape, which do not disappear with pressure. This is spots formed because of formation of microaneurysms. Clinically, we can also distinguish symptoms like Kacha symptom and growth symptom. Kacha symptom is hyperesthesia of the skin in the zone of innervation of 8th thoracic vertebra. And growth symptom is the atrophy of subcutaneous tissue on the area of projection of pancreas. And because of this deficiency of 3 types of enzymes, mostly lipase, amylase, proteases, we have signs of insufficiency. Due to disturbance of destruction of lipids, we have deficiency of lipid absorption, and fat-soluble vitamins, also A, D, E, K. That's why it leads to decrease of body weight, bone damage because of D deficiency, clothing disorders because of vitamin K deficiency, because of damaging of amylase, decreased absorption and digestion of carbohydrates. It leads to asthenia, fallen muscle tone, convulsions, and also it may deterioration of intracellular abilities, possible development of hypoglycemic reaction to insulin, and because of deficiency of proteases, we have disturbance of protein digestion and absorption of proteins. It results in decreasing body mass, swelling of lower limbs, swelling or edema because of hypoproteinemia developing, and also signs of hypovitaminosis, iron deficiency, and B12 deficiency anemias, degeneration of internal organs including liver, myocardium, nitrogen balance disturbances. Developing of dystrophic and then atrophic changes in the mucous membrane of duodenum. It's very closely connected in duodenitis very closely connected with the secretin and cholecystokinin production. Deficiency of endogenous secretin leads to an increase in pressure in duodenum, spasm of sphincter of OD, and increase in pressure in the pancreatic duct. A decrease in the volume of secretion of bicarbonates, which leads to an increase in viscosity and decrease in outflow rate. Decreasing secretion of bicarbonates leads to a decrease in pH in duodenum, which in turn contributes to the inactivation of lipase and aggravates the violation of fat digestion. You remember that lipase activation occurs in condition from 6 to 8 pH. The first stage in the development of exocrine insufficiency in patients with chronic pancreatitis is decrease in lipase production, which occurs about 10 years after the onset of disease. How we can diagnose the exocrine pancreatic insufficiency? We can diagnose by invasive tests and non-invasive tests. Invasive tests includes requiring the introduction of an intestine probe, which includes the direct probe methods and indirect. There are two kinds, direct and indirect. And also non-invasive test. Let's start from the quality coprology. It's also very important. Quality coprology can show us general criteria of exocrine insufficiency, and in quality coprology you'll see increased content of neutral fat at normal level of the bile acids, increasing content of undigested muscle fibers, presence of stool of large fragments of undigested food and starch. It means steatorrhea, creatorrheas, and myelurrheas. You remember from other topics also what does it mean. And also we can check quantity determination of fat in feces. Methods and based on the fact that after intake of 100 grams of fat with food, excretion with feces occurs up to 7 grams of neutral fats and fatty acids per day. And increasing its number indicates disorders of digestion and absorption of fat or steatorrhea. Increasing more than 20 gram production, it's steatorrheas. And it's very good methods and which can give you evidence to prove diagnosis of exocrine insufficiency. This is our test as fecal elastase 1. Normally, its production of this elastase 1 is from 200 to 500 milligram per gram of feces. When we have less than from 100 to 200 micrograms per gram of feces, it's moderate mild degree. Severe degree, it's less than 100 microgram per gram of feces. Also, we use the diagnosis as a blood test. In 25% of patients, they give us leukocytosis and acceleration of ESR. Results of determines the activity of pancreatic enzymes. Pancreatic activity enzymes like amylase, lipase, trypsin of blood and urine. Increasing activity of alpha amylase, and first day of activation of disease, exacerbation of chronic pancreatitis or acute pancreatitis will be in 85-90% of patients. But on the second day after exacerbation, only 60 to 70% of patients they have increasing these enzymes, and third day of disease, only less than half of patients they have increasing enzymes. That means that increasing of enzymes in blood or urine is not evidence of decreased pancreatic juice production. This is evidence only of those facts that our pancreas are pancreas damaging, not can represent real production of enzymes. Instrumental diagnosis. This ultrasound examination in ultrasound examination we see increase pancreas exacerbation, and also we see sclerosis. Also we should be able to assess contours of this gland, heterogeneous structure, and places with reduced echogenicity, and also it will be visible pancreatic duct, expansion of pancreatic duct. Here is a normal pancreas, which is seen in ultrasound investigation, and here radiography of abdominal cavity by plain X-ray. Normal on plain X-ray there is no visible pancreas, but here because of calcification it become to be visible. And also we can use CT scan to diagnosis of pancreatitis, and it will be see pseudocyst, central pseudocyst. Also to detect the neighborhood organs damaging, and to detect the hypertension in pancreatic duct, we can use endoscopic retrograde cholangiopancreatography, and this is all about the pancreas. And that's why, as a result of discussing pancreatic insufficiency syndrome, we should be able to put diagnosis first because of typical clinical picture, and second because of observation, and third we should based on lab and instrumental test. Lab test as increasing enzymes is not effective for diagnosis of pancreatic insufficiency. The good methods is of course this stool test, and of course this assessing of elastase-1 test in feces. And now we continue our lecture by syndrome of inflammation of the gallbladder and biliary tract, or cholecystitis and cholangitis syndrome. And here is anatomy of gallbladder and pancreatic duct, or gallbladder duct and pancreatic duct. They have common output, and you see pancreatic duct and gallbladder duct, they have common output to the duodenum, and that's why the disorders of gallbladder and disorders of pancreas, they are closely connected with each other. And here is a variant of inflow of common duct and duct of pancreas into the duodenum, and you see different types of inflow of these both ducts. And for example, in this structure, in this variant, it will be very difficult if any stone formed in common bile duct can also result in obstruction of this common duct, and can cause the increasing pressure in pancreas, pancreatic duct also in pancreas. Etiology of etiology of cholecystitis and cholangitis, of course, on the first place, this infection, any kinds of infections, as Escherichia or Streptococcus, Staphylococcus, and parasites, and etc. And contributing factors, this stagnation of bile, changes of the chemical properties of bile, dyskinesia or of gallbladder and bile ducts. And one of risk factors, of course, this is overeating, and not only overeating and fatty and spicy food, just disturbance of regime of time and regime and frequency of eating. To distinguish these disorders, we also should know about dyscholia, this violation of chemical properties of bile and physical chemical properties of bile is normally ratio of bile acids and their salts to cholesterol is 2 to 1. If the cholesterol increase 10 to 1, it precipitates to form stones, and when will associate our cholecystosis will associate with formation of stone, cholelithiasis. And symptoms in cholecystitis consist of pain syndrome, syndrome of gastric dyspepsia, syndrome of intestine dyspepsia. Why gastric dyspepsia and intestine dyspepsia? We need bile production to emulsification of fats, and if there is no production or decreased production of bile, our fats not emulsificated, and which result in steatorrheas. Also, bile we have as a stimulator of GIT to peristalsis of stimulation of GLT, and there is no bile will be result in constipation. Also, bile has a bactericidal effect, and there is no bile will develop any growing of microbes in a GIT system. Also, may associated syndromes like neurological and autonomic disorders, autonomic disorders, and psychoneurological disorders. Objectively, during examination, we'll find icteric sclera, skin, if we have disturbances of going out bile duct, like obstructive cholestasis. On that kind, we have increasing of direct bilirubin level in blood, which result in icteric sclera or skin. It is very rare. Temperature, because of cholecystitis, this is inflammation, will increase and may sometimes with tachycardia. In the right if we develop cholemia syndrome, vice versa will develop bradycardia. And in the right hypochondrial muscle tension of the anterior abdominal wall we can find by palpation methods, and soreness of the care point, and palpation. During palpation we can detect the enlarged, painful, strained gallbladder, and this is see what does it mean? Care point. Care point. This is point of gallbladder. This will be very painful. This is point, this hypochondriac region, which crossed by the rectum muscle border. This is care point. Lab and instrumental, of course, blood test shows us leukocytosis, and leukocytic formula shift to the left side and may increase USR. And in case of cholestasis, will increase cholestatic enzymes in blood as GGTP and alkaline phosphatase. In case of involving of liver into pathological process, will may increase ALT and ST level, but it's not character for cholecystitis. And very important method is, of course, ultrasound method. This first diagnostic procedures, and in ultrasound methods we'll see first wall of gallbladder and thickening of wall of this gallbladder and amount of gallbladders, and also any stones and size. And here is stones, and different kinds of stone can accumulate in gallbladder. Next methods of MI colonography. We get imaged bile duct, gallbladder, pancreatic duct, and neighborhood organs. and may detect that cholelithiasis, jaundice, violation of duct, anomalies and structure of various diseases, and of course CT scan. And that's why in these disorders it's very important to detect the clinical picture and detect the lab test, and of course we can use any visualization method to diagnosis of cholecystitis. Okay, dear students, thank you for your attention. If you have any questions, feel free. You can connect with me by WhatsApp or by any sources. See you later.